first three talks. But now it's my pleasure to introduce the next speaker, who is Gordon Plant. Gordon is one of the most sought after speakers all over the world. I count him as a very old friend and as a great source for knowledge. And today he is going to share with us his thoughts about positive visual phenomena. So we'll get started right now with Gordon Plant.
Thank you so much to the organizers for inviting me to give this talk on positive visual phenomena. I have no competing interests. These are the topics we're going to cover, starting with terminology, which is a bit of a mess. So phosphenes are sensations of light generated at some point in the visual pathway, such as the retina or visual cortex. They are not photopsias. Photopsia is the disorder in which phosphenes are experienced, as with erythropsia, hemianopsia, etc. Entoptic sensations are visual sensations that are generated within the eye itself. You will often see the word entopic used for this in publications. This is quite wrong. Entopic is the opposite of ectopic. We don't use it very often. It refers to an organ that's in its proper position. Floaters, on the other hand, are the shadows of debris or cells in the vitreous on the retina, and these can only be seen when there's light entering the eye. The Eigengrau or Eigenlicht refers to the spontaneously generated appearance of grayness that we all have in the absence of light, which is not the same as the color black. Visual snow is a description of a visual phenomenon which resembles analog TV static, which those of you my age will remember. Curiously, it was usually referred to as the War of the Ants in Scandinavia, who seemed to see the black dots rather than the white dots. Teichopsia is a zigzag morphology of a phosphene most commonly associated with migraine, and visual hallucinations generally refers to more formed images. Technically, these are pseudo hallucinations if the patient has insight, i.e. knows that they're not real. So spontaneous visual sensations. As I say, we all see something in the dark, which is not really complete absence of light. And Horace Barlow was very interested in this as a possible, possibly arising from noise in the visual pathway, perhaps generated in the photoreceptors. The problem with that is that we should see both light and dark. We should see positive and negative from the on and off systems in the retina. And perhaps is this more like what we would see if there was visual noise, as visual noise, this TV snow. And this, of course, is now become extremely important in terminology because of the condition which is known as visual snow. And one possibility is that this is awareness of visual noise, but patients vary as to whether they see this in the dark or only as interfering with daylight vision. Visual snow is one part of a syndrome. The patients often complain of various combinations of these other symptoms, what I call persistent after images, other people call palinopsia, jumping text when reading, starbursts around lights, tinnitus, tremor is a feature, and also seeing light through closed lids. So visual snow was put on the map in 2014 when we and others described this as a new syndrome, and there's a recent review showing where we are in the science. The blue field entoptic phenomenon. This is something we can all see, not often here in London because we don't often get a clear blue sky. But I hope you can see on this GIF, these represent white blood cells, really the gaps between the columns of red blood cells going through the capillaries in the eye. And anyone can see these looking up at a blue sky. Sometimes people notice them and think they've just appeared so they may go see an ophthalmologist thinking there's something wrong. And some time ago, they were actually used to monitor progress in the treatment of leukemia. So phosphines can also be induced. The commonest are deformation phosphines, and these, of course, are much more visible in the dark because they're being generated in the retina, and they were extensively studied by Professor Grusser in Berlin. And anyone can experience these by pressing on the eyeball, and of course you see the inverted image, you see it in the opposite field. These were very important historically because they were used as evidence that the eye can actually emit light. And the emission theory of light, which was based on the idea that the eye emitted light, dominated thinking in Western medicine and philosophy for centuries. Newton, of course, realized that this was not right, and that what your finger was doing to the retina was just simulating what light did. And this was eventually confirmed by Morgagni, who did the first experiment of sitting in the dark with a friend, pressing on his eye, and when he could see light, his friend couldn't. And he actually used phosphines to predict the outcome of cataract surgery. So other induced phosphines, not enough time to go into all of these in detail, but I will mention phosphines on eye movement. This can be a normal phenomenon. We think this may be stimulation of the retina by the eye muscles, but it also occurs in optic neuritis and occasionally with optic dysdrusen or other optic nerve tumors and so on. And the patients will say that they see a flash of light when they move the eye in the dark. So like retinal phosphines, these are washed out by normal light. And of course, vitreous detachments will also produce this kind of phosphines, which are evoked by eye movement, but maybe also head movements. Phosphines in retinal disorders. Well, all the ophthalmologists are familiar, of course, with vitreous and retinal detachments. And attempts have been made to differentiate the different types of phosphene entoptic phenomena here in this particular study, looking at the difference between PVD and macular degeneration. But it should be emphasized again that these are all washed out by normal light. So they're sometimes confused with migraine, but cortical phosphines are not. And here is an example of the big blind spot syndrome. On the left there, you'll see the colors, which for many, many years, we couldn't see any abnormality. But here in this outer retinal disorder, you see the autofluorescence, and looking back, well, perhaps it did look a bit abnormal, but we could never see it back then, hence occult. But these are outer retinal disorders, which are usually associated with phosphines localized to a scotoma. And here you can see on the OCT of that same patient, the outer retinal disruption. Another retinal cause of phosphines is melanoma-associated retinopathy. And this is a very interesting one because it's not due to structural damage. It's due to an antibody which is blocking the effect of the bipolar cells. And this causes nyctalopia and also constant phosphines, which can be very disruptive. Lastly, we come to migraine and epilepsy. Now, the major feature of migraine phosphines is their duration. This is the first question you must ask if you're trying to distinguish something that might be arising in the retina from something that might be arising as a migrainous phenomenon. The duration of migraine visual aura is many minutes, maybe up to 20 minutes. And during that time, the visual experience will evolve in some way. It will change. And as I said before, these phosphenes are equally bright in the darkness or looking up at the noon sky because they are generated with a signal brightness. And that doesn't change, doesn't matter what's happening in terms of light falling on the eye. And that's a big distinction from things arising in the retina and the optic nerve. And of course, there may be associated headache, but acaphalgic migraine, so migraine aura without headache, is very common, and particularly in older patients who may never have had migraine before. So you will see many patients, older patients, coming with visual aura. They don't know what it is, and it gets mixed up with detachments and all sorts of other things. The other characteristic are the morphological features, and Teichopsia or zigzags is the most common. Another is like looking through running water or heat haze, or an image that's fractured or broken up in some way. There's many variations on this, but these are fairly common. So you need to also inquire exactly what the patient experienced. I mentioned the term Teichopsia meaning zigzags. It actually means, it's from the Greek for wall vision, and it refers to this bastioned fortification, which was very common in continental Europe, as we call it here in Britain. But we didn't need these because we always relied on our navy. So we don't have examples of towns like this, or at least not many. One on the border with Scotland. It turns out that the term was actually coined by Hubert Airy, who had migraine and did produce many beautiful illustrations of his own migraine aura, which have been published repeatedly. And he was referring to this appearance of a bastion fortification when he coined the term Teichopsia wall vision, and also known as fortification spectrum. And this has many interesting features. The Zigs and Zags get larger as they move out in the visual field, and this relates to the representation of the visual field on striate cortex, which is part of the evidence that this may be where the aura is arising. The zigzags themselves could be generated by these cortical, the cortical representation of orientation, which is within modules throughout striate cortex. And some time ago, I got a patient to plot out the size of the zigs and zags of his migraine across the visual field, and produce this power function, which fits quite well with the cortical magnification factor, as it's called. And we now know from fMRI studies, very difficult to get patients in an fMRI when they're having a migraine, that we have evidence there that the migraine aura is arising in visual cortex, and the phenomenology of it, the speed at which it progresses across the visual field fits very well with it being generated by this type of abnormal electrical disturbance in cortex, which is known as the spreading depression of Leon, who was a Brazilian physiologist who first described this. And he was what he was describing as depression was the electrical silence that follows the activity, and that fits with, if we go back to, oops, wrong way. If we go back to the drawing here, you can see here, this is a blind area. This is a scotoma following on from the leading edge of the zigzags, and that fits very well with the spreading depression theory. Now, what about occipital epilepsy? This is, of course, much more serious because it may be due to an occipital tumor. These episodes are very brief, I mean, generally less than a minute in duration. The location in the visual field tends to be very consistent if these are generated by a localized tumor rather than a constitutional type of epilepsy. And they're more often unformed phosphenes. Quite commonly, they are colored blobs. And Panatopoulos, who was an epileptologist working at St. Thomas's, one of my hospitals in London, he asked some patients with occipital epilepsy to make drawings. And you can see here that these two patients here drew these multicolored blob shapes, nothing like the zigzags of migraine aura. Another patient sent this in. He said, I can't draw, but this is what it looks like. This is Christmas wrapping paper. These are colored baubles. And here's one that was a bit different. But these colored blobs are quite common, and we can relate these to another feature of visual cortex, which is where these, they're actually called blobs because of their appearance on cytochrome oxidase staining. But within each of these hypercolumns in cortex is an area that processes color. And perhaps that's where the migraine aura is, the migraine aura generates zigzags, lines, and an epileptic aura generates colors. I'm often asked who with migraine aura needs scanning. Well, generally, it's not necessary. You can make the diagnosis from the clinical description. But if the aura is always starting in the same place in the visual field, or if there's any field defect, of course, or if there's any evidence of more persistent, less megranous sounding episodes, like very brief flashes occurring as well, these are all hints that this might be due to an occipital lesion. I reported really over the course of about 30 years, I only ever saw 20 odd patients who had occipital tumors causing a migrainous-like aura. And we wrote these up in this article. And this was one of the patients. This up on the left here, you can see his drawing of his migraine aura, and this was caused by a localized cavinoma. So it always started in exactly the same place in the visual field, and in fact the attacks responded very well to valproate. So there's a very quick summary of the various aspects of positive visual disorders, and I think we're going to have some time for questions. Thank you very much for listening.
Thank you, Gordon.